Good afternoon, everyone from Zagreb, Croatia. Greetings also to Liverpool and Gothenburg and to all Europe, to everybody who is watching us today. My name is Ivan Fistonić. I'm professor of gynecology OBGYN in Rijeka. It's also the second big town in Croatia. And my topic is menopause, and yeah, published several articles and also a laser technique to treat GSM. My team has published the first articles dealing with the GSM, and everybody who is writing about this today is referring to our articles. Well, today's webinar is dedicated to genitourinary syndrome of menopause, a chronic and progressive condition associated with estrogen deficiency that affects a large proportion of women during the menopausal transition, as we know. But also, do not forget their partners as well. Despite its high prevalence and its significant impact on quality of life, sexual health, and overall well-being, GSM often remains underdiagnosed and undertreated in our clinical everyday practice. Clinically, GSM symptoms may significantly affect daily activities, intimate relationships, and also psychological well-being. Fortunately, of course, our understanding of GSM and its management has evolved considerably over recent years. Today, a range of therapeutic options is available, non-hormonal as well hormonal therapies, particularly low-dose local estrogen therapy, which remains one of the most effective and well-established treatments. Other options such as SERMs or DHEA have also expanded our therapeutic armamentarium. And in addition, there has been growing interest in EBDs, energy-based devices, such as the laser and radiofrequency treatments. Today, we have a firm evidence of laser's efficacy and safety, and laser is not hype anymore. It is evidence-based therapeutic modality in precisely selected patients. We are therefore particularly pleased to have with us today Professor Jan Milsom from Gothenburg and Dr. Paula Briggs from Liverpool, whose extensive competency and clinical experience make them the ideal experts to guide us through this important topic. They will share their insights and practical recommendations regarding the diagnosis and management of GSM. Who is Professor Jan Milsom? Although Jan Milsom was born and raised in UK, he received his medical degree from the University of Liverpool in UK. It's interesting that we are all connected with Liverpool. Paula is still at university. Jan was there at his residency, and I spent several months of my internship in the old Royal Infirmary on Pembroke Place. Okay, let's go back to the Jan. Because his postgraduate training was carried out in Gothenburg and he stayed there for now. He is currently the head of the Women's Hospital and Queen Silvia's Children's Hospital with Sahlgrenska University, Gothenburg, Sweden. Professor Milsom is the author and co-author of numerous publications within the field of female reproductive health, which includes urogynecology as his main topic of interest. Jan Milsom is author and co-author of more than 4 research works. And this is an incredible fact that he has been cited more than 40,000 times. And most cited, is his fundamental EPIC study, Survey of Urinary Incontinence in 5 countries. So, with his impressive credentials and expertise, Professor Jan Milsom is certainly the right person to guide us through this topic. So, Jan, the screen is yours.
Thank you very much indeed, Ivan. You're so kind. I'm sharing my screen now with you, and my topic today is genitourinary syndrome of the menopause. We shorten a lot to GSM, and my task is to tell you about the pathophysiology, the prevalence and symptom burden of GSM. Before I do that, here are my... Here are my disclosures on funding, which you can look at quickly. Well, the genitourinary syndrome of the menopause is a common condition. It affects many postmenopausal women due to reduced levels of estrogen in the body. It causes symptoms like vaginal dryness, burning, painful intercourse, urinary urgency, and there is an increased risk of urinary tract infections in women who have the genitourinary syndrome of the menopause. There is a large variation in levels of circulating estrogens during a woman's life. Here I've a picture depicting the whole cycle of a woman's life, starting with the little baby girl on your left. When she's newly born, if one was to do a vaginal examination on her, you would see that the vaginal epithelium was estrogenized due to the estrogen levels in the mother. But when she then gets to the age of about 2 or 3 months, then things change quickly. And if you were to examine again at that time, you would find that the vaginal epithelium has changed character and remains so until the girl enters puberty, has menarche, and starts producing her own estrogens from her own ovaries. This continues during her life. In the 30s, 40s, there is a slight decline in estrogens, which may accelerate quickly in some women, but in most women, the menopause occurs at about the age of 51 years. So there is a decline in estrogens from 30, 35 years of age to the menopause, and even continues after the menopause. We do have some women who unfortunately have a premature menopause, and GSM symptoms can occur in them despite that they're much younger age. Here is some terminology that we use. The menopause, as I say, usually occurs at about the age of about 50, 51 years of age. When it starts varies. There's a large inter-individual variation. Women with a premature menopause can experience symptoms of GSM as early in the late 30s and 40s. Symptoms similar to GSM do occur in women who have recently delivered a baby or who are breastfeeding. So there are even other groups of women who have problems with vaginal atrophy. Most of the symptoms associated with GSM can be attributed to the lack of estrogen that characterizes the menopause. Although GSM mainly affects postmenopausal women, it may also be seen in many perimenopausal women who experience an increasing dryness of the vagina that may have effects on their sexual life. In the female genitourinary system, there is a common embryological origin to the urinary tract and the reproductive tract. It is the urogenital sinus that later develops into the urinary tract and to the reproductive tract. And in these systems, there are estrogen receptors that have been demonstrated in the vagina, the urethra, and the pelvic floor muscles. And this has been known for many years. The symptoms that occur because of the genitourinary syndrome of the menopause are due to reduced lubrication. There's an increased dryness. Women feel irritation. They may experience burning and itching. Some women may have a discharge due to the changed bacterial flora in the vagina. Many women experience pain during exercise, but also pain during sex, giving rise to dyspareunia. The physiological changes in the vagina are notable following the menopause and may occur even in some women prior to the menopause. The epithelial membranes become thinner. The folding of the epithelium is reduced. There is reduced elasticity, reduced secretions. The width and the length of vagina is reduced, and this is particularly the case in older women who have not received estrogen treatment. The bacteria flora of the vagina changes quite radically, and there's an increase in pathogenic bacteria in the vagina following the menopause when there are low estrogen levels. During the fertile period, women have a large proportion of lactobacilli, which prevents the growth of more pathogenic bacteria, and this may lead to a change in the vaginal microbiome in the vagina in postmenopausal women. The genitourinary system of the menopause also affects the urinary tract. Many women experience dysuria. There's an increased risk of urgency, and there is also an increased occurrence of urinary tract infections. The increase in urinary tract infections can be attributed to the changes in the vagina, in particular the changes in the vaginal microbiome with the increased number of pathogenic bacteria. There is also an increase in the prevalence of urinary incontinence in postmenopausal women. The question then arises, how many women suffer from GSM? What is the prevalence of GSM? Well, there have been numerous studies. I'm quoting just a few of them here. These are some of the more recent studies that have been done. But as you can see, dryness, pain with sex, irritation, and tenderness is extremely common in postmenopausal women. And if you combine these symptoms together, then perhaps 50% of women will have symptoms of GSM. Vulvar and vaginal atrophy are common, and this has been studied in 4 European countries in the European Revive study. And here you can see the occurrence of dryness, irritation, tenderness, pain during intercourse, bleeding and pain during exercise that occurs during the pre-menopause, the menopause, and the years after the menopause. As you can see, these are highly frequent problems. The last study that I'm showing you is a study that shows symptoms such as vaginal dryness, dysuria, urinary frequency, decreased moisture in the vagina, the loss of the vaginal eurygy, elasticity is changed, which can influence the woman's sexual life. There are changes in the width and the length of the vagina, which also influence sexual activity. So, these symptoms all have a negative influence on the quality of life due to, in part, vaginal symptoms, the occurrence of vaginal dryness, irritation, burning and itching. There is a thinning and graying of the pubic hair, which some women can displease. Vaginal pelvic pain and pressure may occur. Also, be the increased occurrence of urinary symptoms, painful urination, dysuria, urinary urgency, urinary incontinence, both stress and urge incontinence, and the increased occurrence of recurrent urinary tract infections. The occurrence of these vaginal and urinary tract symptoms, and in particular dysuria, pain in the vagina, lead to sexual symptoms such as painful sexual intercourse. The decreased lubrication during sexual activity can be a problem. This may lead to bleeding during sexual activity, which in turn can decrease arousal and loss of libido, and leading to an inability to achieve orgasm. In summary, then, up to and perhaps even more than 50% of postmenopausal women report vulvovaginal atrophy symptoms. And if we look at the situation in the United States, then there are approximately 32 million women who have GSM at present, but only 2.3 million are currently being treated with prescription therapy. So there is an underdiagnosis and undertreatment. Life expectancy is increasing, and women and men are living longer in many countries. And it is not uncommon today that a woman will live for a further 30 years after the menopause. A 70-year-old woman today can have a physiological intellectual capacity that a 50-year-old woman had 30 years ago. So GSM is a common, troublesome condition that affects the millions of women who are living an active life after the menopause. It's important that they seek help as treatment is available. Thank you all very much indeed. Ivan.
Are over with your presentation. So thank you very much for your presentation. And I would like to announce, we will have discussion afterwards, of course. Ne? And I would like to announce our dear Dr. Paula Elizabeth Briggs. She is a prominent British medical consultant specializing in women's sexual and reproductive health at the Liverpool Women's Energies Foundation Trust. And she's an honorary clinical associate professor at the University of Liverpool. She's currently the immediate past chair. She was president of the British Menopause Society until late months in 2025. Her professional background is fixed to her role at the University of Liverpool, where she serves as consultant in sexual and reproductive health as a public advocacy. Dr. Briggs is a frequent commentator in media regarding the so-called menopause industry, which should be stressed more often than it is. And recently, she is warning against the overprescription of testosterone, which became like a fashion nowadays. She is currently chief investigator in research, aiming to develop the first drug specifically for premenstrual dysphoric disorder. And we are all eagerly awaiting the results, Paula. So her key area of expertise is, of course, menopause management, and her clinical focus includes urogenital atrophy and the management of menopausal symptoms in women with a history of hormone-dependent cancers, which we'll discuss afterwards. And considering her expertise, we are really fortunate to hear Dr. Briggs' insights and recommendations on GSM. So, Paula, it's time to share your slides with us. Please go ahead.
Can't you see the slides now?
Yes.
Oh, amazing. Okay. Thank you, Ivan, and thank you, Ian, for your really good talk. So this part of the presentation is going to focus on how to diagnose GSM by raising awareness of the impact of low levels of estrogen on urogenital tissue quality so that women can access treatment earlier. Oh, hang on a second. So this is my declaration of interest slide. So I'd like to start with a discussion in relation to nomenclature, as that's where the confusion begins, in my opinion. So the favoured term is neither of these, vulvovaginal atrophy or urogenital atrophy, rather genitourinary syndrome of menopause, GSM. So GSM, and there are other terms like senile vaginitis and many others, but it's a normal, could be considered a normal part of the aging process, but it's also a treatable medical problem. And information needs to be made available to women to help them understand that this is not something that they need to put up with. GSM is chronic and progressive, so it gets worse without treatment, and it responds best to treatment initiated early in the patient's journey. But of course, that depends on the correct diagnosis. Urogenital symptoms, whilst very common, are not as clearly identified with menopause as vasomotor symptoms. They're intermediate symptoms, meaning that they start 3 to 5 years after women become menopausal. So really, because it doesn't become an issue for several years, that connection with menopause is lost, and that's one of the reasons why women will accept this as part of the aging process and not ask for help. As Ian said, symptoms include vulvovaginal dryness, itching, burning, pain with sex, and recurrent urinary tract infections. And those can adversely impact health and well-being, including sexual function, which in turn impacts on mood, both amongst affected women, but also their partners. Women are often reluctant to volunteer information about sexual problems without being asked directly, although GSM potentially affects anything up to 80% of women, and we'll talk about prevalence a little bit later. So basically, the true prevalence, in my opinion, is unknown. It could be anywhere between 50 and 80%. As I've already said, women are reluctant to disclose symptoms unless they're asked specifically about them. And that results in a delay in diagnosis, leading to more severely affected tissue quality, which is more difficult to treat, with symptoms often taking as long as 6 months to respond to the various different treatment options available. There is presently no recognised, accessible and validated clinical assessment method with which to diagnose GSM, and that influences research outcomes, but more importantly, it impacts access to an accurate diagnosis and treatment for affected women. It is a silent epidemic. GSM is underdiagnosed and undertreated. We think 50% of women roughly will wait 6 months before seeking help. And this slide highlights the varied reasons for that. And 25% will wait more than 6 months before seeking any help. And as I said before, the response to treatment in GSM is better with earlier intervention. So once the diagnosis is made, there are many different treatment options available. So why are women affected by GSM not coming forward for treatment? So the reasons are varied and include a lack of awareness, embarrassment. Some of the treatments are messy, they take months to work, and some women are still concerned about hormonal treatments, even those delivered vaginally. But the main reason, in my opinion, is that there is no recommended method of diagnosis. So the diagnosis will depend who the patient presents to. In my clinical practice, if the patient is peri or postmenopausal and they've recently become symptomatic, then this increases the likelihood of GSM. I also think it's important to examine the patient to rule out other conditions like lichen sclerosus, lichen planus, VIN, or even cancer. So it's helpful to be clear, I think, about the underlying disease process responsible for the symptoms and signs that we've mentioned. The mucosal layer in the vagina becomes thinner. There are colour changes which range from pallor to inflammation, sometimes with petechiae. As Ian said, there's a reduction in elasticity, shortening of the vagina, loss of rugae, resorption of the labia minora, and sometimes there's fusion over the clitoris. So all of these clinical signs are very similar to what's seen in lichen sclerosus, but the treatment are very different. In relation to the histology and the impact on the microbiome, there's a reduction in the number of superficial cells in the epithelial layer. In a healthy vagina, there are a higher number of superficial cells which shed regularly every few hours, and the cells that shed are loaded with glycogen, which supports lactobacilli. In GSM, there's a reduction in lactobacilli and an overgrowth of other organisms. The microbiome becomes rich and diverse in women with GSM. We know that the urethra becomes more prominent, and it's short in women anyway, and therefore there's a very easy route to cause urinary tract infection. And I think if we provide women with the correct information, then it supports them to access the correct treatment. So to treat the underlying cause of the problem with hormonal therapy, or obviously there are other therapies available, which Ivan talked about at the beginning of the webinar. I think this is a useful diagram. It highlights the importance of estrogen to maintain a healthy vaginal microbiome with predominance of lactobacilli, reducing the risk of UTI. And that's reflected by the pH of the vaginal secretions being less than 5. And this diagram highlights the process leading to the rise in the pH of vaginal secretions in women with GSM. It's generally speaking more than 5, alongside the rationale for the increase in the risk of UTI and pain with sex. Historically, a diagnosis of GSM was based on the Vaginal Health Index developed by Gloria Bachmann in the early 1990s. Using this tool, a lower score is indicative of a less healthy vagina, with scores of less than 15 suggesting a diagnosis of GSM. This intervention was never used in routine clinical practice, where diagnosis remains a clinical decision based on the experience of the clinician that the patient presents to. The Vulval Health Index addresses some of the deficiencies in the Vaginal Health Index in relation to the vulva specifically, but it's not been validated. And a higher score in affected women suggests a GSM diagnosis with a score of more than 8 or a score of 3 in any category deemed confirmatory. The GSM assessment tool was developed by the International Society for the Study of Women's Sexual Health and the North American Menopause Society. But as with the Vulval Health Index, and as with the Vulval Health Index, scores are 0 to 3, and you add the scores together. So a score of less than 7 is consistent with mild GSM, 7 to 14 moderate GSM, and a score of more than 14 severe GSM. But again, this tool was never validated, but it did form an important stepping stone for something that I was involved with, the new GSM assessment tool, which was part of a study that I undertook that only completed fairly recently, the VAN study, Vaginal Health, What's Normal. And we have plans in place for validation of that assessment tool, which will be referred to as NGAT. So I think I've touched obviously already on the fact that we don't know what the true prevalence of GSM is, because there's no, no way in which to make a confirmed diagnosis currently. I undertook a systematic review, and that confirmed a need to introduce a reproducible clinical diagnostic method for future research, but also in day-to-day clinical practice, particularly in primary care, so that affected women can be diagnosed without delay, enabling them to access treatment in a timely manner. In clinical practice, use of a validated questionnaire, including a question about most bothersome symptom, and measuring vaginal pH using narrow range pH paper, which is easily accessible, could make a massive difference to early diagnosis and access to treatment. And I think that has huge implications in relation to costs, when we think about the costs of untreated women, not just financial costs, but also emotional costs. The COMA, which is Core Outcomes in Menopause Global Initiative Group, have agreed a core outcome set based on symptoms. However, their recommendations lacked consensus in relation to any of the following examination criteria: genital appearance as assessed by a clinician, vaginal elasticity measured by stretching, vaginal pH, which reflects acidity, vaginal maturation value, or endometrial histology. And so whilst these recommendations represent, again, a step forward in relation to a diagnosis, I personally think that GSM should be confirmed by diagnosis to rule out other potential causes of vulvovaginal symptoms. And that was recommended by the European Vulvovaginal Epidemiological Survey, EVES. So a little bit about the study that I undertook. We used 5 different interventions to determine whether there was concordance between those diagnostic methods and whether an optimal option exists for diagnosis. And also, we wanted to look at novel diagnostic methods which could potentially be adopted in future to improve diagnosis and management of GSM. So the 5 diagnostic methods employed in this study were a questionnaire DIVA, which is a validated questionnaire, day-to-day impact of vaginal aging, We looked at vaginal maturation value, so counting the number of superficial cells compared with parabasal and intermediate cells. We undertook a clinical examination using the new GSM assessment tool. And we also looked at the vaginal microbiome and the metabolome of vaginal secretions. So what we were looking at doing with this study was addressing a research question. Is there concordance of information gathered from different methods to assess urogenital atrophy, genitourinary syndrome of menopause with the current standard, which is a clinical diagnosis by a physician? We had 60 women recruited. And as I said, we used DIVA, and that covers 4 main areas: activities of daily living, emotional well-being, sexual functioning, and self-concept and body image. We also undertook a clinical examination using NGAT to improve objectiveness, because it provides a score, and I'll show you that in a minute. We looked at vaginal maturation value, and we assessed vaginal secretions which were collected using a medical standard tampon. So NGAT comprises a scoring system, like I said, and it's based on the features described in this slide. The clinical signs, which were described earlier in the presentation, are awarded points, as you can see, to give a diagnostic score. And a total score of less than 5 is consistent with mild GSM, 5 to 10 moderate GSM, and more than 10 severe GSM, with the maximum score being 15. So this is a very simple concept. We developed an insert in collaboration with Vernicare, who make speculi for vaginal examination, and that raised awareness about changes in tissue colour. But the important part was on the tail of the insert, and that allowed us to give a value to elasticity. So if you're unable to open the blades of the speculum at all, that is allocated a high score because the patient's more severely affected. And if you're able to fully open the speculum, that will take you to the purple tag on the tail, then that scores 0. Vaginal maturation value, as I said before, involves cell counting, generally by a histopathologist, and it's been deemed to be gold standard. But, you know, it is susceptible to human error. I think when we send something for histology or to pathology, we'll get an absolute robust answer. But interestingly enough, we had our cell counts checked by a second histopathologist, and both got quite different results. So I think that shows the difficulty in identifying those cells that you see on the right-hand side of the slide. In relation to cell counts, a value of 0 to 49% for superficial cells suggests an absent or low estrogenic effect, 50 to 64% a moderate estrogenic effect, and 65 to 100 a high estrogenic effect. So we used 16 srRNA, next generation sequencing, for identification of microbes, which would otherwise be very difficult to culture. And we used NMR spectroscopy for identification of metabolites. And women with GSM were noted to have lower levels of lactate and other amino acids, which are typically found in eubiosis, which is a healthy state, together with an enrichment of molecules derived from anaerobes and gut microbes. There were 9 significantly differentially metabolized metabolites in the before and after treatment groups. And the treatment with anything, we weren't looking at treatment, we were looking at the best method to make a diagnosis and assess improvement with treatment. Formate, which is linked to steroid synthesis pathways, is known to be associated with dysbiosis, which is an unhealthy state, and levels decreased following treatment. O-phosphocholine is associated with streptococcus, and that's a pathogen from community state 4A, which is the community state associated with GSM. Carnitine is a biomolecule synthesized from lysine and methionine, and it contributes to long-chain fatty acid transportation and plays an important role in membrane integrity and the function of mitochondria. and inadequate levels of carnitine are associated with several pathological conditions, including age-related diseases like GSM. With a highly individualized vaginal microbial diversity, it's unlikely that assessing vaginal microbes will result in a test which is specific enough to be used as a method of diagnosis or treatment efficacy for GSM. But the vaginal metabolome looks promising in relation to a specific test which could be used to detect, for example, form-8,5, O-phosphocholine, or carnitine. So this is a really exciting area, and this could be a point of care test that women can do in their own home potentially, but we're looking to the future there. So the correct diagnosis, and we've highlighted this at several points during the webinar, is required prior to initiating treatment. And the recently updated NICE guidance provides really clear information about GSM treatment, but treatment is not the focus of today's webinar. The BMS consensus statement on GSM was updated at the end of last year, and it's going to be published in the March 2026 edition of Post-Reproductive Health. This patient resource is available in paper copy, but it's also freely available in electronic format from the Karger website. And this Karger Fast Facts course is also freely available via the Karger website, and that's hopefully going to help raise clinician awareness of urogenital atrophy, now more commonly known as GSM. And of course, the more clinicians that we are able to provide the right information to, the more likely that is to have a beneficial effect on patient care. So just to conclude this brief presentation, ask the right questions. Is there any vaginal dryness, itching, burning, pain during sex, or urinary problems? Examine the patient. Be aware of treatment options. And it's important that women, once treated, continue treatment long term, because if they discontinue treatment, then they're likely to go back to where they started from. So the symptoms and signs will not resolve long term without ongoing treatment. So really happy to join the discussion. I'm going to stop sharing my slides now.
Thank you very much. Thank you very much, Paula, for this comprehensive and very nice presentation. And it is really not common to use these diagnostic tools as you used in this VAN study. So is it still in research, or do you use it in UK like a normal tool in everyday practice?
No, it's early days. So I genuinely think we could improve diagnosis in primary care just by asking about most bothersome symptom and using the narrow range pH paper. That would make a huge difference.
Because one of the questions was, how can we balance microbiome in postmenopause?
By treating the patient generally with vaginal estrogen to improve the superficial epithelial layer, so that we have the kind of healthy functional function, which involves the regular shedding with the glycogen to support lactobacilli. I mean, the problem, I think, or part of the problem, is that women may present with urinary tract infection. They may be treated with antibiotics quite appropriately, but that also has an impact on the vaginal microbiome, and it's then a sort of almost a self-perpetuating cycle that they're in. So I think taking that step back and looking at treating the root cause of the problem is really important.
Mm-hmm. There is also, let's say, some kind of comment from Estonia. When you have problems with the regular atrophy due to estrogen deprivation, and also you have problems with microbiome, are we always to detect both, or how can we manage this situation if it is overlapping?
Sorry, I missed that. I'm busy looking at the question about why I disagree with testosterone prescribing, which I don't, by the way. I just think it's overused, and women are often disappointed. Sorry, tell me the question again.
The question was from, I will read you now. So, misclassification between GSM and microbiome problems may therefore lead to inappropriate treatment. This is a question from Mia Golub. So, do you have any idea how these two partially overlapping conditions can be reliably distinguished in clinical practice?
So look, I don't think they're two separate problems. I think they're the same problem. I'd be interested to know what you think, Ian, because
I was going to answer it the same way. The
Uh-huh.
two are connected.
Uh-huh.
Due to the changes in the low estrogen levels, you get a change in the bacteria flora in the vagina. We've even done studies on immunoglobulins in the vagina, and the immunoglobulins are produced locally. There are low levels in women with lactobacilli, but when you get pathogenic bacteria and the microbiome changes, then you have a change in the body defense mechanisms, and you get an increased production of immunoglobulins locally in the vagina. This we have demonstrated in studies. So the microbiome is a very important part of GSM, a change in the bacteria flora. Lactobacilli aren't as common. In fact, they may not exist at all. And there are a large number of different types of pathogenic bacteria which can increase the risk for irritation, pain, sexual problems, increased number of urinary tract infections. So I think these two things are very closely connected.
Mm-hmm. And when you are here on the screen, there is a question for Professor Damir Franić from Slovenia, and he asks very briefly, why are you against of the usage of testosterone in postmenopause? Because he understood that you are against.
No, in the UK, I think that prescribing has increased astronomically. We never used to have patients who were disappointed in menopause clinics, and the number of women now crying when they come to the clinic because their sex drive hasn't improved, nothing's improved. Sex drive is very complicated, and testosterone is one piece of the jigsaw, but it's not the only thing. And we need to look at urogenital health, don't we? Because if you've got GSM and sex is painful, you can give as much testosterone as you like, but somebody's sex drive is not going to improve. So we provide women with a trial of testosterone, but we say to them, we'll reassess your symptoms at 6 months, be really honest. If it's not helping, then stop it, because it's another thing to do and to monitor. And at the end of the day, we want women to feel empowered to manage their menopause, to have access to treatment. We're doing loads of collaborative work with GPs and primary care to ensure that that happens. But yeah, I think just giving testosterone to everyone is not necessarily the right answer. And
I think with libido, it's a multifactorial problem. There are many things behind libido that can affect libido in a negative direction. GSM is an extremely important factor that influences many women, but there are social factors, things at work, many different things can influence problems with children, that their environment in general can affect this. So, but GSM is extremely important.
But we are talking about testosterone. There are only two indications for testosterone. If you are surgically in menopause without your ovaries, immediately then the level is falling down. This is the one thing. And according to the recommendations of international sexology societies and IMS and EMAS and all, only indication is dysphoric disorder in menopause. Nothing else. I understand. And we have only one cream that is conventional in the world, as far as I know. This is this Australian cream. Do you use it, Paula, in UK?
We can't prescribe it on the NHS yet. We use it privately, but we use male products outside of license for women.
So we have to switch now. The question, always is the question, if I'm a lady of 40s and I am breast cancer survivor and I'm castrated by chemotherapy and by radiotherapy, and what will I do to enhance my sexual gratification? Lubricants only, or we have another possibility?
Do you want to take that? Me?
Yes.
So for women who've had breast cancer, it's now acceptable to use vaginal estrogens, and the only really area of controversy is in women who are using aromatase inhibitors, and that's on the back of a study which had more than 50,000 breast cancer patients looking at end mortality. And I think that's been really reassuring for women with breast cancer. I mean, they are the patients who have the worst GSM. They
What would you recommend, Paula? What would you recommend as a therapist?
So if it's a patient who's not on an aromatase inhibitor, and we do occasionally use estrogens in women who are using aromatase inhibitors generally with collaboration with the breast surgeons and oncologists, but the preferred product is estriol. It's a weaker estrogen in the lowest dose.
Yes.
So we tend to use a pessary, which has got 30 micrograms of estriol. But some women don't. There are various different preparations,
But we can
aren't
also
there?
use, Paula, we can also use this 17 beta estradiol as well. If we use low dosage, as I understand in UK, it is over the counter, which means something. So if you use these 10 micrograms tablet, you will not rise your estrogen in your blood more than 30 picograms per liter. So for
Yeah.
ladies who are here, who are wise and who understand, they can use also vaginal estrogen. Why not? But also there are some questions now.
I would like
What
to
is
comment on that as well, Ivan. The question about breast cancer patients. I think it's a good thing to use vaginal estrogens. Vaginal estrogens, and in particular estriol, which is a weak estrogen, we have studied what happens to estriol when you give it vaginally in women. What happens is that their epithelium becomes thicker. The amount that's absorbed over time gets lower and lower and lower. So there is some absorption early on, but after about 2 weeks,
it goes down?
this absorption is minimal. So I think in this respect, and there are guidelines substantiating this, that vaginal estrogens in women with breast cancer, okay. The question regarding aromatase inhibitor, that's perhaps a little bit different issue. But in general, I think we should help these women who have a lot of problem with these problems without incurring more problems with them, giving them vaginal estrogens.
Yes, yeah, but I'm the lady who I simply do not want any age of hormones, any age, letter age. What would you then recommend? She doesn't want. We are pushing her, but she doesn't want.
Laser.
Bravo. Yes, that's the right answer. Because I will just tell you a small story. My dear colleague, Professor Gambacciani from Italy, from Pisa, he made perfect 5, 6 years ago study when he compared the effects of estriol, vaginal cream, and the laser. So, two groups of ladies, one estriol, one laser, for 3 weeks, let's say. Afterwards, he stopped both therapies. Symptoms were totally again present in estriol group, but in laser group, it remains lubrication for more than 6 months. So the same effect. So we need not to, we have to offer a laser in these situations. Also, if you ask me, in situations of lower grades of stress urinary incontinence, because if a lady is not obese, if she's not a heavy smoker, if she has some other parameters, she can expect reduction at least in 30% as our study shows. So laser is the option, of course.
So we need the RCT with sham laser that NICE have requested.
We have
but in the UK, they want it in the UK.
Yes, okay, but you have one RCT multi-center from UK, you should check. There is another thing, because we are lacking time. There is another thing I wanted to discuss also.
I comment on that.
Yes, please.
Regarding laser and vaginal estrogens.
Okay.
I would say vaginal estrogens are a lot cheaper, a lot easier to do.
Yes,
Been
but she
shown
doesn't want.
in RCTs.
She doesn't want. So laser is a good option.
It's good to have choice as well, isn't it?
I have another question I would like to
And it's
discuss.
very quick. The results are very
It is.
quick.
Yes, they are. I have another question we have to discuss. How do you comment, both of you, please, this controversy? If we are talking about stress urinary incontinence, after WHI, okay, we know it's a bad design and blah blah blah, but there was the result was regarding worsening of ACUI symptoms in those who used MHT. How is it possible? Because on other hand, we have improvement in some lots in disease symptoms of incontinence. So how do
That's for
you,
Ian then.
sorry?
That's a question for Ian.
This
There's,
is a controversial issue. Studies have shown, as you say, there's an increased occurrence of stress urinary incontinence with women using systemic hormonal replacement therapy. I think this is you have to look very carefully at the studies that have been done, the ages of the women chosen, the doses of estrogen given. There was a period when we saw this in our studies that there was an increased occurrence of stress urinary incontinence and even urge incontinence occurred. But this was due to the fact that many people believe that estrogens would generally stop stress urinary incontinence, which is basically another problem rather than a hormonal problem. It's more a question of what is supporting the pelvic floor, and that, okay, there are estrogen receptors, but the damage has been done, in my opinion, mainly through vaginal delivery, which is the main cause, and not because of the estrogens.
okay, thank you. But I have also, I think I have the answer because you have to divide urgency, and stress urinary incontinence, where estrogen will help in urgency, of course. But in stress urinary incontinence, we have a problem. This her study and WHI, they apply this estrogen to the ladies who were really in a respectable age, where estrogen receptor beta is dismissed totally. And beta receptor is key for the strength and for collagen production in estrogen therapy. So this is the answer. Start before 60 and you will get the results. And I would also like to stress something that you, Paula, also mentioned in your, and I think this is the most important here. How to, because ladies are reluctant to use the therapy. Yes, they are.
There might be.
And yes, and our is to ask them about sexuality and about incontinence. Every woman that enters in our office. So I think the answer is here, but the problem is time. What do you say?
It doesn't take that long to ask, does it? I mean, I kind of said that.
Yeah, of course. Or you can put in your waiting room FSFI, ICIQ questionnaires, and then you'll get the answer, of course. What else to ask you? What do you want to comment?
Yeah, I wanted to comment. You were talking about urgency in stress urinary incontinence. With regard to urgency, it increases with increasing age in women compared to stress incontinence, you can say. One of the changes that occur, there are also atrophic changes in the urinary bladder. So if you do a cystoscopy and look at women who've never been taking estrogens, you see that the inside of the urinary bladder has changed in appearance compared to the same woman if you looked at it during her fertile period. And this increases the risk for urgency. So the same type of problems that occur in the epithelium in the vagina also occur in the urinary bladder.
Yeah, that's the answer also. Okay, there is a now you raise the question of the epithelial atrophy intraurethral epithelial that is very thin. So it loses collagen also not only vaginal wall but also in urethral wall. So we have a possibility. Only one device in the world has possibility to treat intraurethral laser, RBMAG laser, treating intraurethral, and you will get from thickness. You will get really epithelia that will produce more and more cells, and it will be much more competent because about 30% of collagen is in urethral epithelia. So if we combine intravaginal laser and intraurethral laser, maybe we will get more results. Not maybe, this is evidenced. Anything else you want to comment, Paula?
Yeah, so there's a question in the chat about adding vaginal estrogen for GSM in women who are using systemic MHT. And I think that's a really important point. I mean, the best treatment for GSM is vaginally delivered hormones, in my opinion. And I think it's really important that clinicians will add vaginal hormonal therapies. And obviously there are other treatments, aren't there, like, you know, DHEA delivered vaginally, and ospemifene, which is a SERM. So you wouldn't add that necessarily to MHT, but definitely vaginal hormonal treatments, both estrogens and DHEA, which I think has quite a unique role because of its conversion to testosterone within the vaginal mucosa.
Yeah. There is a question: is vaginal estrogen more efficient than oral or transdermal in the treatment of GSM?
I think definitely.
Definitely.
Yeah.
Okay, so what else we have? Blah blah blah.
There's a question about the study, which I just can't remember what it's called, but it was published in January 2024. It's an observational study with 50,000 women in it. If I remember it, maybe somebody can pick it up later.
Telling what?
About the use of vaginal estrogen in women with a breast cancer diagnosis and their all-cause mortality.
Yes, of course. And there is yes, you are right. And there is no rise in the relapse of the disease. So really, I do not have any obstacle to offer a local vaginal estrogen in small dose, of course. So, dear all, thank you very much for being with us. And I would like to say bye-bye, but I would like to conclude today's webinar in GSM. I would like to Professor Milsom and Dr. Briggs to thank and sharing their invaluable insights, evidence-based recommendations, and practical guidance on the diagnosis and management of GSM. So finally, thank all participants for joining us today, for your questions and for your engagement. And we hope you leave this webinar with the new knowledge, practical strategies, and renewed confidence in managing GSM. So we look forward to seeing you at future sessions and continuing this important conversation on women's health. So have a nice day, rest of the day. Bye-bye.
Bye-bye.
Bye.